So what is the problem here is acute ischemic stroke. 800,000 Americans suffer from a stroke each year. And in the US, this is the leading cause of adult long-term disability and the fifth leading cause of death. And worldwide, stroke is responsible for more deaths annually than AIDS, tuberculosis, and malaria combined. So obviously a very big public health problem. And stroke, as we know, by and large, is a disease of the elderly, but not always. In the US, patients over the age of 80 represent 4% of the population, but account for almost 30% of strokes. And as expected with an aging population, the incidence of stroke is only going to go up. So this kind of sets the stage of the problem that we're talking about today. So I know a lot of our audience are stroke patients or patient interested in stroke. So I just wanted to kind of go over everything, kind of from A to Z. So to begin with, what is an acute ischemic stroke? So essentially, there are different kinds of strokes, but this is the most common kind, as it kind of happens when a blood clot lodges in a brain vessel and puts the brain beyond the blockage at risk of death from lack of oxygen and nutrients. And the diagram here on the right side, as you can see, there's a blockage in the artery, which is the red part of the diagram. And then the area kind of supplying by the artery beyond the blockage, it's a risk of dying because of lack of blood flow and nutrients and oxygen to it. So in essence, this is what an acute ischemic stroke is like. So why do people get strokes? So what are these clots that block that artery comes from? So these are the common places. One of the most common places is actually from the heart, what we call cardioembolic strokes. Another common place is actually from other arteries. For example, it could be from arteries from the neck. I'm sure you have heard of carotid artery narrowing. So carotid artery is a common place. It could also be from smaller vessels in the brain beyond the carotid artery. So between the heart, the neck, and the brain vessels, it probably account for about 60% of all the strokes. And there are some rare causes of strokes, especially in younger people, such as dissection, kind of injury to the artery, or some clotting disorders that patients have. And interestingly, despite all the fancy tests that we have, still about 30% of patients will never know where the clots really came from and why they had the strokes, and we call this the cryptogenic strokes. So again, in quick review, a stroke is a blockage, or ischemic stroke is a blockage of the artery supplying the brain. And this clot can come from the heart, from the neck vessels, from brain vessels, rare causes, and sometimes we just don't know why the strokes occur. The take-home message on the talk is that stroke is both preventable and treatable, unlike what most people think. So these are the modifiable risk factors. So of course, there are risk factors that we can't help: age, sex, ethnicity, and hereditary factors. But there's actually a slew of risk factors that are modifiable that we should pay attention to. For example, blood pressure, heart disease that we talk about. A lot of the strokes, the clots came from the heart, like atrial fibrillation, diabetes, high cholesterol, cigarette smoking, alcohol use, and physical inactivity. So again, keep in mind that stroke is actually a preventable disease, and there are a lot of modifiable risk factors that we should pay attention to. It's important for this talk, because I'm a neurosurgeon, we're going to talk a little bit about the treatment of stroke. So what is a large vessel occlusion? So we talk about stroke is caused by blood clot lodges in the brain artery. So for the purpose of this discussion, the internal carotid artery, which starts in the neck or in the chest, or actually in the neck all the way up, in the middle cerebral artery, and you can see on the diagram here, this box. So if you have a clot in the internal carotid artery and the middle cerebral artery, we consider this a large vessel occlusion. We'll kind of get back to it a little bit later. So this is what it's like. This is the recent diagram from the blockage of the Suez Canal. So essentially, you're talking about a blockage of the carotid artery or the middle cerebral artery, and these are major arteries supplying blood flow to the brain. So important for our patients, kind of in terms of what are the symptoms. So how can you recognize if you're having a stroke or the family members having a stroke? So there's a acronym, BFAST. B is balance. So sometimes you're off balance. E is eyes, as we can see on the slide here, that the eyes, you could have visual loss, or the eyes can be deviated to one side. Facial droop, the F is for the face, A is for the arm, S is for speech, can be both aphasia or slur of speech, and T is time. Remember, time is brain, and we kind of go over that concept a little bit more as we go along. So this slide, I put it in for our EMS colleagues, if anyone from EMS is listening in. So how do we assess strokes kind of before the hospital? So there are a few popular scales. There's the Cincinnati Stroke Scale, the LAMS, Los Angeles Motor Scale, and also the RACE score. So these are basically nice scales, nice simplified scales that EMS can use in the field to assess the patient having severe strokes. And you can see here on the Cincinnati scale, if you're 2 or above, you're having severe stroke. The LAMS scale, if you're 4 and above, you're having like a severe stroke. And um, the reason to do this is because you want to triage the patient to the right hospital setting. So if you're having a large stroke, you want to go to a level 1 comprehensive stroke center. So most of us know that once you get to the hospital, then the assessment becomes a little more in depth, and the standard scale to assess the severity of stroke is the NIH stroke scale. And if you have a NIH stroke scale of 20 points or above, meaning that means that you're having a severe stroke. And NIH stroke scale goes from a point of 0, meaning normal, to 42, which is the most severe stroke that you can have. So we're just going to go back to this concept of the B fast. The T is time, time is brain, and just to kind of show what we mean by that. So in a typical, again, the large vessel occlusion, this is the severe blockage of the large vessels. Each minute, we're losing about 2 million neurons, 14 billion connections between brain cells, and about 8 miles of fibers, every minute when this stroke is occurring. So it is, it's suffice to say that really time is brain. And in terms of outcome, has been really studied and documented, many studies that every hour lost, when the brain is under occlusion, there's about 20% reduction of good outcomes. So you really want to go to hospital as quickly as you can when you're having a stroke, because because we have treatment that can reopen the arteries. So this is kind of just to summarize the last 2 slides. So basically, you can see on the bottom horizontal axis, that's time, and on the vertical axis, that's probability. So as time goes on, when you're having a stroke, the probability of having a good outcome becomes less and less, and the chance of actually dying from a severe stroke gets more and more as time goes on, and kind of like the point where the 2 lines kind of crosses at the 6-hour mark. So we're at that point, your favorable outcome is reduced to a point that it kind of meets the chance of dying from it. So just keep that, again, the 6-hour mark in mind, and we'll talk about it a little bit later. So we kind of talk about what is a stroke. We kind of talk about why do people have strokes. We talk about kind of how we assess strokes and the importance of timing. So how about treatment? So really, from the beginning of time to 1995, there's actually no treatment available. So in the late 80s, if you have a stroke, you come to the ER, you just be parked aside and basically, hope that you won't have another stroke. However, in 1995, a landmark study comes out, from the NINDS trial that shows that we can actually treat strokes, beyond secondary prevention, and that's the IVTPA, the clot buster that we can give through the veins. And it shows that if you can give the medicine within 3 hours, your chance of having an independent good outcome is much higher than if you don't get the medicine. And 12 years later, that we're able to extend the window from another study called ECAS-3. We're able to extend the window now to 4.5 hours. So the bottom line here is that if you come in within 4.5-hour windows of your symptom onsets, you're eligible for this clot busters, which could provide an improved outcome compared to if you don't get it. So this is really the first major revolution in stroke treatment. Now, so go back to that large vessel occlusion. So why do we keep talking about that? Apart from the fact that I'm a surgeon and we do surgeries to help these patients. So first of all, the large vessel occlusion is actually a pretty common kind of ischemic stroke. So we talk about ischemic strokes. It's about 80% of strokes. There are other kinds of strokes, but ischemic strokes, the one we're talking about, is the most common one, 80%. And about 20% of ischemic strokes fall into this category of large vessel occlusion. And these are the most severe kind of strokes. You have 5 times, compared to other minor strokes, the large vessel occlusion, you have a 5 times higher mortality and a threefold reduction in good outcomes. So again, the most significant kind of strokes. And importantly, these strokes actually don't respond to the IV TPA well, really because the clot burden is too much. So basically, the chance of successfully opening a middle cerebral artery occlusion is only about a third of the time if you get TPA. And if you're talking about the carotid artery, where the artery is even bigger, more clots in it, it's really less than 10%. So most of the time, if you have the large vessel occlusion, the most severe kind of strokes, the TPA is really not going to work. So that's kind of where surgery and endovascular therapy comes in, because that we've developed other techniques to remove the blood clot, and I'm sure you guys have heard about this. I mean, this has made it to news of New York Times and then and other media. So basically, we have different techniques of going in, through the either the leg artery or the wrist artery, and all the way up to the brain vessel to retrieve the blood clots, either through these stents. You can see on the left side, we're going to deploy the stent. And I'll show a video of that at the end. And we pull the blood clot out, or we can just put a catheter up like a vacuum, and you can kind of use a vacuum to suction and pull the blood clot out. So this is important for these large vessel occlusions that don't respond to TPA. So really, what is the evidence behind this? So now we're kind of moving into some of the evidence of why we do what we do, So in 2015, there are 5 major trials. It's really a golden year for stroke therapy that proves that these stents are beneficial to patients to pull the blood clot. But these are the criteria that you have to fulfill if you're a stroke patient. So first of all, we have to use this new technology called the stent retriever, which was on the diagram I showed previously. The treatment got to be done quickly. We talked about the 6-hour window in one of the previous slides, because to get a good outcome, or to have the highest chance of a good outcome, you should do as quickly as you can within 6 hours. And you have to have a fairly large clot burden. So that's why we define a large vessel occlusion again in the carotid artery and the middle cerebral artery. And the stroke symptoms got to be very significant. So NIH stroke scale of about 17 here, which is really the moderate to the severe, going to the severe kind of strokes. So if you fulfill all these criteria and you have the blood clot removed, your chance of having an independent outcome in 3 months is much, much higher if you have this therapy compared to if you don't have this therapy. And just to give you an idea of how beneficial this therapy, I want to introduce this concept called number needed to treat. So you see here in this study called the Extend IA, there are only 3 people there. So that means that you only got to treat 3 patients in order to save 1 additional patient from essentially going to the nursing home. So again, it's a very beneficial therapy. You need to treat 3 people to have 1 additional stroke patient to be functionally independent at 3 months. So just to put that in comparison, you see on the very bottom of the diagram here, for coronary, for heart intervention, for heart attacks, you got to treat about 17 patients to prevent 1 patient from having another MI, stroke, or death. So this stroke therapy is actually much more efficacious even than the coronary intervention that we often think is really beneficial. And I hear a lot of our colleagues basically equate this as giving antibiotics for sepsis. So it's a really kind of beneficial treatment. So that's why this is like a really major advancement in the therapy of stroke since 2015. So then the next question comes about. So now we're going to go more into the data and the science. And certainly, if you have any questions, please kind of jot them down, and we can discuss them at the end. So we talk a lot about if you come in 6 hours, have a big clot, you should get the clot retrieved. How about if you come beyond 6 hours? Can we help these patients? So in the beginning, we really were kind of skeptical. But unfortunately, people do the studies and the science show that if you select the patient properly, so even in patients that came beyond 6 hours, there are certain patients that are still very beneficial from this therapy. As you can see here, for that group of patients that are properly selected, that the chance of getting a good outcome, again, at 3 months is much better if you get the therapy, what we call the thrombectomy, which is the removal of this blood clot in the brain, compared to if you don't get it. And again, the number needed to treat, the same concept I'm talking the last slide, is about the same. So again, if you choose a patient correctly, even if you come beyond 6 hours, it could be very beneficial. So how do we select the people beyond 6 hours? So we have kind of some advanced, or if you like, fancy kind of imaging modalities. And the idea is that you want to pick the people when they come into the hospital beyond the 6 hours, they have a relatively small stroke at the time, and they have a large area of brain that are still salvageable because they have good collaterals, pathways to the area at risk. So we use perfusion imaging to select people who can still benefit from this therapy beyond 6 hours. So for the last kind of 10, 15 minutes, want to kind of talk about kind of where we are and where we're going with the thrombectomy. So where we are is what we kind of talked about. So if you come to the hospital today with a large vessel occlusion in the carotid artery and the middle cerebral artery, and you have a fairly significant stroke, and we can treat you within 6 hours, the standard of care, the gold standard now is to go in and remove the blood clot. So that's the standard of care. Now, what are the unanswered questions and what are the opportunities for improvement? So we don't know if we go to smaller blood vessels. For example, if we go beyond the first bit of the middle cerebral artery, do people still get better? How about we go to other arteries, kind of talking about the anterior cerebral artery, the vertebral artery, the basal artery, the posterior cerebral artery? How about we go beyond the carotid artery and middle cerebral artery? Can people benefit? And how about people, when we talk about selecting patients on perfusion with small strokes, how about people who come to the hospital with bigger strokes? We know that since the therapy is so beneficial for patients, could we be less strict about the criteria? And people come with bigger strokes, so they still kind of benefit. And finally, we talk about, that the people whom we offer the treatment to these days are people who have pretty significant symptoms. And how about people with the big blockage who are still pretty asymptomatic with mild symptoms when they come, knowing that they may get worse down the line? Should we intervene on these patients? So these are kind of like the unanswered questions. And of course, another big question is that should we still give TPA to these people, knowing that TPA may not work in the majority of them? I mean, there's some kind of pros and cons. The bottom line is that should we skip TPA? So these are all kind of like the unanswered questions at this point. There's a lot of ongoing trials and science kind of guiding us, and I'm kind of going to take the last 10 minutes of the talk just to review some of this here. So going back to the concept of the large vessel occlusion, can we redefine that? Can we expand that box that we talked about, just from the carotid artery and the middle cerebral artery to include other arteries, and more small and more distal vessels? So fortunately for the studies in 2015 that we talked about, they actually did look at the middle segment of the middle cerebral artery. So this is the segment of the middle cerebral artery right beyond that box that I drew initially. So, and fortunately that they showed that even if you go a little beyond that middle cerebral artery, the endovascular treatment still is beneficial, and the treatment effects still favor for having this therapy for a 90-day good outcome. So if you would have a middle cerebral artery occlusion, that is beyond that kind of early part of middle cerebral artery, you should still have the clot removed because the outcomes are better if you do compared to if you don't. So I think this is now pretty clear and pretty well established, and most of us will do that. And I think if you want to go beyond that artery to much smaller vessels, that is when we're really not sure, because the smaller of the blood vessel, obviously the smaller the stroke will be, right? The smaller, it's like the branch of the tree. The further out of the branch you go, the smaller of the smaller part of the brain it supplies, right? So it's basically higher risk because you're going to smaller vessels to pull out blood clots, but the benefit is also lower at that point since you only supply a small part of the brain. So I think at some point, the further out you go, at some point you hit that kind of risk outweigh the benefit kind of scenario. So I think for now we're just going out to the mid part of the middle cerebral artery and really not much beyond that. So how about the basal artery? I'm sure you guys have heard a lot about this. And in fact, there's a New England Journal article that just came out yesterday that I just read this morning to add it to the talk. So, the basal artery, most of us think, well, I mean, we do know that this is the most important artery of the brain. I mean, the basal artery, if it's blocked, it's really, rarely compatible with life. So we do think, most of us do believe that if that artery is blocked, we should do thrombectomy and remove the blood clot. But the truth is that if you look at the literature, the literature is a little bit less clear. Even though I think there is a trend towards functional improvement and better outcomes, but at least, for example, in this review, and meta-analysis that the results or the even though there's a trend, but the results were not significant, and also there's a higher risk of hemorrhage. When we do this endovascular thrombectomy on patients with the vascular artery occlusion. So this is really added slide on this morning. This is fresh off the press from New England Journal of Medicine. So this is a randomized study. So again, the kind of like the highest level of data that we have, kind of they randomized people, from thrombectomy to medical therapy in this vascular artery occlusion. And I think again here, similarly, it does show a trend to benefit. That if you get the thrombectomy, but the results were not statistically significant. So in essence, they didn't quite prove that the therapy is beneficial, even though there's a trend to it. And I think just like the previous meta-analysis, it does show that compared to people who didn't get the thrombectomy, there's certainly a bit of a higher complications in terms of bleeding, which makes sense when you're putting stents and pulling blood clots from the artery. There's a small price to pay to get the outcome. So I think it's hard to say kind of where we're going to go from here, but I would think that most of us who do this procedure think that the vascular artery is important, and I think if we can, we would still like to remove the blood clot. I mean, here there's a trend for benefit, and I think this is kind of what we see in our patients. I mean, I certainly have many of my own patients who really did well from this vascular thrombectomy, but certainly more to come. And this is the next kind of study. There's an ongoing Chinese study, again, a randomized trial that looking at this issue of the vascular artery occlusion. So I'm sure next time we give an update, we'll have more data to come. So how about the larger strokes that we talked about? So we say that this therapy is as beneficial as giving antibiotics for sepsis. So we know that when you choose the patients very carefully, patients get tremendous benefit from this. So how about if you're a little bit more relaxed about the criteria? How about if you intervene in people who already had some strokes when they arrived? And I think, again, it's a bit of an unanswered question, but if you look at this chart here, certainly it shows that even people with bigger strokes, which is indicated here by a lower aspect score, bigger strokes, that these people still have quite a significant benefit from it. So I think, again, most of us, still think that if there is a reasonable amount of salvageable brain tissue, that we should perform the treatment. But having said that, we have to be guided by science, and there are at least three ongoing studies right now to look at the issues of doing thrombectomies on patients with larger strokes, the Tesla, the tension, and the in extremis study. Finally, I want to talk about how about doing thrombectomies on people with large vessel occlusion, but relatively well. I mean, we know that as we talk about with the basilar artery occlusion, the thrombectomy itself is not without some risk to it. And people who come in with relatively mild symptoms, I mean, historically, we do not typically intervene in these patients, but we've seen some of these people can get worse since the artery is blocked. They may decline, deteriorate over time. So should we perform it? I mean, right now we're not really sure, and we really kind of take it on a case by case basis. And of course, like all the other question we're trying to answer, there are two randomized trials that are trying to answer this question of low NIH or low stroke symptoms, the ENDO-LOW study and the MOST study. Finally, the issue with TPA, with large vessel occlusion, do they need to give TPA? This is a recent study from New England Journal of Medicine, basically showing that this is a study from China showing that skipping TPA did not seem to affect the outcome of these patients who got thrombectomy. So again, in this scenario, there are two groups, right? They say two groups. One group of patients got the thrombectomy and the TPA. The other group of patients just got the thrombectomy, and it seems like skipping thrombectomy here did not affect the good outcome adversely. So from this group, I think that's probably okay to forego IV TPA since it doesn't work for this most of the time anyways. But again, there are more studies coming out. One is called Mr. Clean, No IV. I think that study has just been completed in terms of its enrollment. And Swift Direct, actually maybe the Swift Direct is the one who's completed. I gotta go and double check. But these are the two studies that are really trying to answer that question whether or not we need to give IV TPA, Mr. Clean, No IV, and Swift Direct. So what is the goal? I mean, we're talking about kind of all the advancements and thrombectomy and indications. So The goal is that we know 20% of ischemic strokes are from large vessel occlusions, and we're only offering thrombectomy probably to a small percentage of those patients, maybe less than 10%. So what we really want to do is to through science and data show that it's beneficial for many more patients with thrombectomy or with large vessel occlusion and be able to offer them the beneficial therapy.